Good morning. This is Dr. Vyshnavi, your ENT faculty, and today what we are going to discuss is some questions um, for your ENT, and this is going to be helpful for next for NEET as well. So, without any further waiting, let me know if I'm audible and visible to all of you, if the communication is working well, so that we can get started with the sessions. So, I think all good, all okay from your end. Yes, so since we all know that we have the next exam coming up, may not be 2019, but yes, for 20 batch, it's important for us to understand the pattern of questions prior on hand, if not be 100% similar to what you'll have in examination, but a similar replica of the pattern that could be expected in the examination. So keeping that in mind, I have come up with these questions for you from our Pro QBank so that you get a glimpse of what we have in the QBank and also get a practice of the most important topics that I feel for your exams are. So here we have all long stem questions, we have clinical questions, and here we're going to discuss most clinical topics that are relevant for your exams. So hi everyone, hi Michael, hi Yogesh, hi Black Panther and Rafiq Khan. Good morning to all of you again. So let's begin. So we'll start off with the question itself. So we have a 40-year-old patient presenting to you with extreme pain and hearing loss in the right ear. They also experience pain during chewing and jaw movements. On examination, tragal sign is positive and there is a purulent ear discharge from the external auditory canal. Additionally, the retroauricular groove is obliterated. What is the most likely diagnosis for this condition? So, can you all tell me what is the probable answer in the chat box? सो डॉक्टर पिका जो अब आज डिस्कशन हो रहा है हमारे तरफ से यही यही थॉट प्रोसेस है कि जो भी एग्जाम्स में इम्पोर्टेंट हो सारे वो टॉपिक्स कवर हो जाए ये सेशन में ताकि आपको आइडिया आ जाए कि एग्जाम में कैसे क्वेश्चन आ सकते हैं कौन से टॉपिक से आ सकते हैं और वो सारे इंपॉर्टेंट टॉपिक्स मैंने इस सेशन में कवर करने की कोशिश बहुत की है Yes, Black Panther, it will be helpful for FMGE as well क्योंकि टॉपिक्स तो मोर और लेस सेम ही रहेगा सो आपको जो अटेंड करोगे तो यू विल डेफिनेटली हैव बेनिफिट फ्रॉम दिस सेशन So some of you are saying P. Now let us understand the question. The question is saying to you there is pain. Let us look at the keywords. The keywords are pain. The keyword is hearing loss. The keyword is also increases. The pain increases on chewing and jaw movements. And there is tragal sign positive. Tragal sign positive is specific to only one condition. इसके साथ साथ they have given you retroauricular groove is obliterated and furthermore you have purulent ear discharge. So with all these keywords, how do I get to the answer? First of all, options jo hai, whatever the options that we have, let us understand them. Now, when we are talking about acute otitis media, acute suppurative otitis media, now this is a bacterial infection caused by streptococcus. Now, can it present to you with pain? Yes. Can it present to you with hearing loss? Yes. Can it cause increase in pain on chewing and jaw movements? May not be plus or minus. But is tragal sign positive in AOM? Never. It is negative. And when we are saying media, middle ear, when there is a disease in the middle ear, you will never get purulent discharge because the middle ear has got cuboidal epithelium. So cuboidal epithelium will produce to you mucoid discharge. It can never produce to you purulent discharge. It can present to you mucoid or mucopurulent because when the pus comes in the external ear, it becomes mixed with the mucoid to become mucopurulent. But since it is from the middle ear, it can never be purulent discharge. Whenever we are given the word purulent discharge, we should know that the pathology is in the external auditory canal. External auditory canal has got stratified squamous epithelium with hair follicles and sebaceous glands, and hence any pathology in the external auditory canal will result in a purulent ear discharge. So the word that you see purulent, in your mind you should know the disease is not in the middle ear, the disease is in the external ear. That is your first point. The second point, tragal sign is positive. Now, tragus sign is positive is when you push the tragus in, the patient will wince with pain because there is inflammation of the external auditory canal. So again, tragal sign positive is something suggestive to you of a inflammatory disease in the external auditory canal, be it localized or be it diffused. Localized otitis externa is nothing but your furunculosis. So we say staphylococcal infection of the hair follicle, we call it as furunculosis. So when we have these pointers of purulent ear discharge, when we have got tragal sign positive, you must think about the external ear condition. And amongst the options, the only external ear condition is localized otitis externa, and hence the answer. The rest of the diseases, acute otitis media, chronic otitis media, they can present to you with pain, they can present to you with hearing loss. But tragal sign will be negative and they will have either mucoid or mucopurulent discharge, but never they will have a clear purulent discharge. Like a clear cut purulent picture is never seen for any middle ear disease. That's the thumb rule that you should know, that purulent means external auditory canal, mucoid or mucopurulent means middle ear, and hence you will cancel these options of acute and chronic otitis media. Now, when we talk about otitis media with effusion, it's a condition where there is no pain at all. There is sterile fluid in the middle ear. So, when we have sterile fluid in the middle ear, will there be pain? No. Will there be fever? No. What can they present to you with hearing loss? Yes. So, this also doesn't fit in the clinical picture. So, when you know the keywords, it's easier to get to the diagnosis. So I will only tell that look at whether the discharge is mucoid or purulent. If it is mucoid or mucopurulent, you can still think of middle ear diseases. But if it is only purulent discharge, then think about the external auditory canal diseases. So this is your key takeaway from this question, and I hope you understood this. If you've got any doubts, please don't mind to put it in the chat box below. Let's go to the next question. A 45-year-old patient presents with sudden onset of symptoms. They report experiencing vertigo lasting since few days. Along with that, there is hearing loss and there is a feeling of fullness in the ear. The symptoms started a week after recovering from a viral upper respiratory tract infection. On examination, there is no signs of tinnitus, no signs of ear discharge. The patient is otherwise healthy with no significant medical history. Based on the history and clinical presentation, what is the most likely diagnosis of the patient? So, you have very important parameters here. You have vertigo, and you have got hearing loss. But there is no tinnitus, there is no ear discharge, and the vertigo is of few days in onset. Now, with this, what are your answers? So, Rafiq, Smriti, Brinda. Okay, so Swasim, Med Psycho, Rafiq, all of you are a little confused. Brinda, you're right. Lakshmi, you're right. The answer is labyrinthitis. Okay, so first of all, let us understand the question. So, whenever we have a question on vertigo, it is very, very simple to get to the answer only with the duration of disease. First and foremost, if the vertigo is lasting for a few seconds to a few minutes, straight in your head, the first differential diagnosis that should come to you is BPPV. If the vertigo is lasting for minutes to some hours, straight in your head, you should think about Meniere's disease. Now, if the vertigo is lasting for days to weeks, then there are two differential diagnoses. It can be either labyrinthitis or either it can be vestibular neuronitis. So at least this first thing you have followed. If it is lasting for a few seconds to minutes, the first DD is BPPV. Minutes to hours, Meniere's disease. Days to weeks, labyrinthitis or vestibular neuronitis. Now, what is the duration that they have given to you? Few days. So, can BPPV and Meniere's disease be in our answer? Never. They cannot be because they have clearly mentioned that the vertigo is lasting since a few days. So, that will tell you that it is not Meniere's, it is not BPPV. So, let us cut this. Now we are left with either vestibular neuronitis or labyrinthitis. Now, vestibular neuronitis is a condition where there is inflammation of only vestibular nerve. The rest of the labyrinth is not involved, like the cochlea is not involved, hence there will be no hearing loss. So here the patient is having hearing loss. So can it be selective inflammation of only vestibular nerve? Here the patient is having hearing loss, the patient is having vertigo, indicating inflammation of the entire labyrinth, which can happen post-URTI, post-cholesteatoma, post-infection. So labyrinthitis can occur due to any etiology, but how do we differentiate labyrinthitis from vestibular neuronitis? Labyrinthitis will have vertigo plus hearing loss. Vestibular neuritis will have only vertigo, no hearing loss. So I think this is absolutely clear. So with this, we know that it is not vestibular neuronitis. The correct answer is labyrinthitis. So I hope everyone got it. Okay. Now let's go to the next question. A 7-year-old child presents with severe ear pain. So what is the symptom? The patient is having severe ear pain. There is also a bulging tympanic membrane and persistent effusion despite antibiotic therapy for how many days? For 10 days. What is the most appropriate next step in the management of this patient? Okay, so can you tell me what is the most appropriate step in the management? Mohit, if you've done from 4.0 version, it's still okay. If there are any topics that you do not understand or any difficulties in ENT, then you may go for 5.0 version. But whatever is comfortable for you, just stick to it. There is no point in keeping on changing your resources. Just keep on doing the MCQs. The more you practice your MCQs, the better you will be. And wherever you feel that I am lagging or I have not understood certain topics, maybe then you can switch over for those topics to the 5.0 version. Okay. Great. So here, the most of you have answered it absolutely right. Black Panther, Janki, Priti, Sahu, Indian Scholar, and I'd request most all of you to try and attempt the questions while we are doing this, because this will tell you what is your thought process and is your thought process matching mine, because that's more important rather than getting to the answer. Because answer to ऐसे मतलब sometimes we might rule out, we might understand with the question, but we need to know what is the thought behind the answer. So just try and answer during the in the chat box as many people as you can. Okay, so when we have a patient who's 7-year-old presenting to you with pain, bulging tympanic membrane, the first differential diagnosis that should come to you is acute otitis media, also called as acute suppurative otitis media. Now, in acute suppurative otitis media, we have got 4 stages: tubal occlusion, pre-suppuration, suppuration, and resolution. Now, in the stage of suppuration, we have got this bulging tympanic membrane. Now, if a patient presents to you with simple ASOM, no severe pain, no bulging tympanic membrane, no effusion despite antibiotics, then you can go for medical therapy with antibiotics, nasal decongestants, and anti-inflammatory analgesics, etc. But if the patient is presenting to you with any of these 4 indications, number 1, excruciating ear pain with bulging drum, incomplete resolution despite antibiotics, or there is a persistent effusion beyond 12 weeks, or there is a persistent effusion beyond 12 weeks. And if there is a patient who has got ASOM with facial palsy, so if any one of this is also present, then you're going to perform a myringotomy. So what are the indications of myringotomy? The first is excruciating pain with bulging drum, incomplete resolution despite antibiotics, persistent effusion beyond 12 weeks, and if there is a patient with ASOM with facial palsy, then you can go for myringotomy. So here you will not continue the antibiotic or change the antibiotic or give steroids or decongestant. You are not going to do any of this. You are going to straight clear the pus from the middle ear. The tympanic membrane is anyways bulging. The patient is having severe pain. You have given antibiotic and it has not resolved. Then you are going to go for myringotomy. So you need to know from this question what are the indications for myringotomy in a patient with ASOM, and I think now you've clearly understood it. So let's jump to the next question. I hope this pace is fine with all of you. If you find me a little fast or a little slow, you can let me know in the chat box so that I can increase and decrease according to your needs. Okay, a 35-year-old patient presents with painless foul-smelling ear discharge, multiple permanent ear perforation, facial paralysis, severe hearing loss out of proportion to the symptoms. So there is a painless hearing loss, there is multiple perforations, There is facial palsy and hearing loss is disproportionate. Which of the following surgical procedures would commonly be performed in the management of this patient? Myringoplasty, tympanoplasty, modified radical mastoidectomy, or reconstruction of the ossicular chain? Okay, so I see most of you have got it absolutely right. First of all, let's know the diagnosis. If you know the diagnosis, please tab that also because you've already told the answer. So can you tell me what is the diagnosis? Pulse discharge and the word multiple perforation. What does multiple perforation suggest to you? Whenever you hear the word multiple perforations in the tympanic membrane, what is the thing that is suggestive to you of? Because if we have a perforation in the pars tensa, it is tubotympanic type of CSOM, pars flaccida etiquantral type of CSOM. And if you have multiple perforations, what will you think of? Very good, Gaurav. It is suggestive to you of TBOM, tuberculous otitis media. Okay, so multiple perforation is tuberculous otitis media. Single perforation in the pars tensa, it is safe type of CSOM, which we call it as tubotympanic. Perforation in the pars flaccida, etiquantral type of CSOM or unsafe type of CSOM. So with this itself, you will know what is to be answered. For all the three, whether it is safe, whether it is unsafe, whether it is TBOM, most often we will require mastoidectomy. But in your options, you see there is only one option, MRM, modified radical mastoidectomy. So for tubercular otitis media with facial nerve palsy, because the patient is having facial nerve palsy, you have to decompress the facial nerve, you have to remove the disease around the facial nerve and start with an anti-tubercular therapy. So the surgery of choice will be MRM. For aticoantral type of CSOM, again MRM. For safe type of CSOM, you will do a cortical mastoidectomy, not MRM. So here you will do a cortical mastoidectomy plus tympanoplasty. Okay. So this is the treatment for all the three types of CSOM. Again, there are details in the treatment for each one of them, but in gross, if I have to tell you in in a quick learning, this is how you're going to treat. Okay. So I hope everyone is clear with this. Let's go to the next question. A 62-year-old male presents with fever, with headache, and focal neurological deficits. An MRI of the brain reveals well-defined lesion in the temporal lobe of the brain. What sign is typically seen on the MRI in a brain abscess located in the temporal lobe? Is it the ring enhancement sign? Is this subdural collection? Is this intracranial air pocket? Or do you see hydrocephalus? Good, very, very good. I'm sure all of you know this. This is a PYQ as well. So in one of the exams prior, they have given this as a PYQ and the image given was like this. So if you can see a central area which is hypodense and surrounding it, you have got a hyperdense ring. This is called as the ring enhancement sign. So ring enhancement sign in the temporal lobe should suggest to you the possibility of a complicated CSOM, meaning the disease has crossed the middle ear and has reached the temporal lobe of the brain. Now, there are two routes of spread of the disease from the middle ear to the brain. The first route is when the disease erodes the tegmen tympani. The tegmen is a thin plate of bone which separates the middle ear from the middle cranial fossa. So if the disease erodes the tegmen and reaches the brain, it will reach the temporal lobe of the brain. So that is the first route of extension. The second route of extension is it can go from the middle ear to the inner ear. From there, it can go to the petrous apex. So the disease can travel from the middle ear, inner ear, petrous apex and involve the cerebellum, the cerebellopontine region. So there are two routes of spread. The first is via the tegmen. The second one is via the petrous lobe. So you can expect the abscess to happen in the temporal lobe of the brain via CSOM. Also, you can expect a cerebellar abscess as well. But most common is a temporal lobe abscess. So the takeaway key point is not just remembering the image, but also understanding that this can happen in the temporal lobe. Sometimes it can also happen in the cerebellum, resulting in a cerebellar abscess. Okay, so we know the answer is ring enhancement sign. Subdural collection hematoma can happen whenever there is a head injury or a trauma. Intracranial air pocket is suggestive to you of a pneumocephalus. Hydrocephalus is whenever there is dilatation of the ventricles of the brain, whenever there is obstruction to the flow of the fluid or the CSF from the ventricles of the brain. So all of that have no relation with a CSOM patient. So we have fever, headache, intratemporal abscess. The sign that you should check for is the ring enhancement sign. Okay. A 45-year-old female presented with bilateral hearing loss and reports the sensation of better hearing in noisy environment. Now, this itself is so much clue to your diagnosis. On examination, tympanic membrane appears normal, but there is a restricted mobility. A diagnostic test was performed which reveals flamingo pink hue on the promontory. Which of the following is the most likely diagnosis based upon the clinical presentation and the diagnostic findings? Now, this is very simple question. I know all of you can answer this because we have female, middle-aged female, bilateral hearing loss presenting to you with hearing better in noisy environment, which we call it as paraacusis wilsi. Paraacusis wilsi plus tympanic membrane normal plus restricted mobility plus flamingo pink appearance, which we call it as the Schwartz sign. All of them are diagnostic for otosclerosis. Now, this is how the questions can get twisted for your next examination. So, if I give you a long stem question like this, now if we have these keywords, female, bilateral hearing loss, paraacusis wilsi, tympanic membrane normal, or Schwartz sign, if we have any of these keywords, we know the diagnosis is otosclerosis. If they ask you what is the tympanometry finding, they can just keep the entire scenario change and the same, and they can just change the last part. Instead of asking you what is the diagnosis, if they ask you what is the tympanometry finding, what will your answer be? Will you get a type of graph, AS type of graph, AD type of graph, or a B type of graph? What would your answer be if you were given a same question? Correct. Then the answer would be AS. Absolutely right. Now, the same question, if they asked you what is the drug of choice, the medical treatment for a patient presenting to you like this, there is only one drug that we use in the medical treatment of this condition when there is an active lesion. So, in an active patient with otosclerosis, there is a drug. What is that drug? Can you all answer in the chat box? What is that drug that is used in patients with active otosclerosis, which will prevent further progression of the disease but cannot reverse the damage that has been done? No, Chandni, it is not gentamicin, it is sodium fluoride. The only drug that we use in the medical management of patients is sodium fluoride. Now, the treatment of choice can be either surgical or hearing aid. So, hearing aid is the first line of treatment. If the patient does not want a hearing aid, then you will go for surgery. The surgery of choice is stepidotomy with placement of prosthesis. So, what is the understanding that you get from this sort of question? You should know the keywords. Keyword number 1, keyword number 2, keyword number 3, number 4, and number 5. If you know these keywords, you should know the parallel possible questions that could come. And this will give you a holistic understanding of that topic so that in your examination, when you face this question, there is no mental fatigue. क्योंकि brain को already पता है ये question ऐसा है, ये देखते ही समझ में आएगा कि ये otosclerosis है, इसका आंसर यही होगा. तो brain में fatigue नहीं होगा. There will be no lot of chaos in your brain क्योंकि एग्जाम में you are going to have a lot of chaos and confusion. If you know your clinical diagnosis with the help of keywords, there will be no chaos, there will be no confusion, and straight सीधा सीधा answer आपको आ जाएगा. Okay, so try and read things like this so that you will be able to get to the exam with more confidence and to perform even better than you can. So I think that's my hint to all of you. Okay, now let's go to the next question. A 26-year-old female presents with a 3-month history of recurrent facial swelling, facial weakness. The patient reports experiencing episodes of facial edema, experiencing swelling of lips and cheeks. She also has difficulty in speaking and chewing during these episodes. On examination, you notice the facial nerve palsy is present on the affected side. There is no pain, there is no pruritus. Based upon these findings, which of the following is the most likely diagnosis? Is it Melkerson-Rosenthal syndrome? Is it Bell's palsy? Is it Ramsay-Hunt syndrome? Or is it angioedema? Okay, so again a confusion for all of you. See the first word, इसमें क्या keyword है? I told you please look at the keyword. The first keyword that you should look for is recurrent facial palsy. Okay. In Bell's palsy and Ramsay-Hunt syndrome, there is a recurrence, but do we see as much as recurrence in as in Melkersson-Rosenthal syndrome? No. Second thing, are there any vesicles in the area of distribution of facial nerve? Is there pain? No. So can we cancel Ramsay-Hunt syndrome because vesicles is predominantly a feature? There will be hearing loss and there will be pain along the area of distribution of the facial nerve. Has that been mentioned? That is not mentioned. Now, what is mentioned here? The patient is having swelling of lips and cheeks. Now, also the patient is having difficulty in speaking because there is a fissure tongue. Why is somebody having difficulty in speaking? Now, when you have an ulcer simply on the lips or on the tongue, can you speak well? We cannot. So, the patient is having difficulty in speaking because of fissure tongue. Now, what is this triad where you see recurrent facial nerve palsy, swelling of the lips, and fissure tongue? Yes, the correct answer is going to be Melkersson-Rosenthal syndrome. In Bell's palsy, you will not see any swelling of the lip. You will see classical features of facial nerve palsy, which is sudden onset palsy with deviation of angle of mouth, loss of nasolabial fold, inability to close the eyes, no facial symmetry. All that is suggestive to you of Bell's palsy. So here the patient is having facial nerve weakness, facial nerve palsy, swelling of the lip and swelling of fissure tongue. This triad is suggestive to you of a syndrome which we call it as Melkersson-Rosenthal syndrome. Now, what are the other conditions where you can have recurrent facial palsy? Now, we said that Melkersson has got recurrent facial palsy. Now, let's understand which other conditions can have recurrent facial nerve palsy. The first option is sarcoidosis. The second is tumors of the facial nerve. So when the tumor is just originating in the initial phases, you can have a recurrent facial nerve palsy. The third one is diabetes. So these are the other three conditions where you can get a recurrent facial nerve palsy. But if you get a triad or a combination of swelling of the lips and fissure tongue, then go for Melkersson. But you should be aware of the possible other reasons why you can get a recurrent facial nerve palsy. Okay? ठीक है. Fine. A patient with conductive hearing loss undergoes otoscopy, revealing a red and bulging tympanic membrane. So, otoscopy is showing to you red and bulging tympanic membrane. When the pressure is applied to the external auditory canal, the tumor vibrates vigorously and changes the color to pink and brown. What is this clinical sign called as? So this is again a very, very important sign. Conductive hearing loss is the complaint. On otoscopic examination, you are seeing something that there is a red and a bulging tympanic membrane. Now, on applying pressure in the external auditory canal with the help of a Siegel's pneumatic speculum, this red color bulge is bulging, it is vibrating, excuse me, and it is changing the color to pink and brown. What is this sign called as? Very good, the diagnosis is glomus tumor, absolutely right. But what is your sign called as? So in glomus tumor, there are various signs, some clinical signs and some radiological signs. The clinical signs that we see in glomus tumor, the first sign is called as rising sun appearance. So you will see that there is a tumor, a reddish hue coming from the floor of the middle ear. This sign is called as rising sun appearance. The second sign, when you apply pressure in the external auditory canal, the tumor vibrates vigorously and then becomes pale. That sign is called as brown sign. Now, when you compress the artery, the carotid, what will happen? The blood supply to the tumor will become obstructed and hence the tumor will become pale. So that sign where you apply pressure on the carotid makes the tumor pale. That sign is called as Aquino's sign. So here, what sign are we talking about? We are talking about brown sign, which is a pressure generated sign. Okay, yes. Gaurav, Phelps sign and salt and pepper appearance are radiological signs. So Phelps sign is seen on CT scan. A contrast enhanced CT scan will show a Phelps sign, and salt and pepper appearance is seen on MRI. So these are your radiological signs, while the rest of the three are your clinical signs. Okay. A 55-year-old male presents to dermatology clinic with gradually enlarging nose. On examination, you notice a bulbous, enlarged, and disfigured nose with prominent sebaceous glands. The patient is concerned about the cosmetic appearance of his nose. Which of the following is the most appropriate treatment for this patient's condition? Administration of oral antibiotics, corticosteroids, or removal of the tissue with laser photodynamic therapy? Yes. See, if I ask you what is the treatment of choice for rhinophyma, which is nothing but hypertrophy of the sebaceous gland seen in acne rosacea, seen in elderly and in diabetics, all of you would tell me the answer is surgical excision of the hypertrophic tissue with laser, and if required, skin grafting. So here they have given to you in a clinical format. So they might twist a simple, easy one-liner question with that of a clinical STEM question, and I think it's quite easy. Enlarging nose, sebaceous gland hypertrophy, disfigured nose, all of this is telling to you that it is rhinophyma. And for rhinophyma, the treatment of choice is going to be your surgical removal with laser. Okay, this is a simple question. A 35-year-old presents to you with complaints of nasal obstruction, rhinorrhea, sneezing. So, three prominent symptoms: obstruction, rhinorrhea, sneezing. Examination shows the patient's serum IgE level to be within the normal range. Which of the following conditions is responsible for patient symptoms? Now, very easy: nasal block, sneezing, or watery nasal discharge, which we call it as rhinorrhea. See, first of all, here they have given to you all the symptoms which are similar to that of allergic rhinitis. And I'm happy most of you have answered this right. But is this AR? No, because IgE level is normal. So whenever the serum IgE level is normal, then it is not allergic rhinitis. For diagnosing allergic rhinitis, the preliminary feature is IgE should be elevated. So when allergy IgE is normal and the symptoms are similar to that of allergic rhinitis patient, then we call it as non-allergic rhinitis, also called as vasomotor rhinitis. This occurs due to imbalance between the sympathetic and the parasympathetic nervous system. There is a sympathetic hypoactivity and a parasympathetic hyperactivity, resulting in symptoms of nasal obstruction, watery nasal discharge, and sneezing. Yes. So I hope all of you got it right. And of course, asthma requires you to have again IgE to be elevated because even that's a hypersensitivity reaction. Sinusitis will also present to you with features of nasal blockade and discharge, but usually again it is a mucoid or a mucopurulent discharge, not a watery nasal discharge. And it does not necessarily have to have IgE to be normal. They can present to you with headache, facial pain, postnasal drip and cough. That is specific for sinusitis. Okay. Now, this is a little tricky question, but let's see how many of you will answer this right. A patient presents with persistent nasal discharge and a CSF rhinorrhea is suspected. Which of the following tests will be most useful in confirming the presence of CSF? Now, this is little tricky, but I'm sure some of you will still get it right. I was sure that most of you are going to answer this. Yes, or if I was also asked the same question, I will mark beta 2 transferrin test. That is absolutely right. But beta 2 transferrin is present in CSF, it is present in perilymph, it is present in aqueous humor. So it is not just present in CSF. But beta trace protein is a component of beta 2 transferrin. It is a component of the beta 2 transferrin. Here, beta trace protein is more specific, present only in CSF. It is not present in other fluids. So, if you now had to choose between the two, which one will you choose? Of course, beta 2 transferrin is the gold standard. I'm not saying no, but this is a recent advance. If they ask you specifically amongst beta 2 transferrin and beta trace protein, now what would you answer? Yes, this is a little tricky. That's why I told you. Then the answer is going to be beta trace protein. So please remember, if this is not there in the option, if it is not there, then definitely go for beta 2 transferrin. If beta 2 transferrin is there and beta trace protein is there, then better to choose beta trace. Okay. So I hope all of you got this right. I hope nobody will make this mistake in the examination. Okay. A 65-year-old male with a history of hypertension presents with recurrent episodes of epistaxis. Nasal endoscopy reveals multiple bleeding points in the nasal cavity. So there is epistaxis and there is multiple points, no single point. What is the most appropriate step in the management? Surgery, embolization, direct therapy, or indirect therapy? I'll give you a clue. What does direct therapy mean? Direct therapy means cauterization of the bleeding area or a bleeding point. Indirect therapy is anterior nasal packing or posterior nasal packing. So this is what is the meaning of direct and indirect therapy. So now can you tell me what will you do? There is not one point. There is bleeding that is happening from multiple points in the nasal cavity. So what will you do now? Will you do surgery? Will you do the embolization? Will you do direct therapy or cauterization or indirect therapy? Okay, so there is a mixed answer that I see. So quickly, if I had to give you a summary of management of patients with epistaxis, so if anybody is presenting to you with bleeding from the nose or epistaxis, the first thing is medical review and resuscitation. You have to take the questions from the patient of hypertension, drug abuse, whatsoever, and resuscitate the patient by giving crystalloids and colloids. After doing this, you must try and examine the nose whenever possible. So on endoscopy, if possible, if you have that equipment, on endoscopy, if you see a single bleeding point, what will you do? You will apply direct therapy. What is the meaning of direct therapy? You are going to cauterize the bleeding point. But on endoscopy, if you see multiple bleeding points, or if you do not have endoscopy at all, because you're in a rural practice, there is no endoscopy equipment at all, then you will think that there is a multiple bleeding point and you are going to do indirect therapy. Not direct therapy, indirect therapy. What is indirect therapy? Anterior nasal packing. If this fails, then you're going to go for posterior nasal packing. If posterior nasal packing also fails, then you're going to go for surgeries. The surgery is the first artery that you will ligate is going to be sphenopalatine artery. The second one is going to be internal maxillary artery. The third one, external carotid, and the fourth one, ethmoidal artery. So that is in general a quick review of management with patients with epistaxis. So single point is the criteria for direct therapy. Multiple point is a criteria for your indirect therapy. And if indirect therapy fails, then you'll go for surgery. Now, surgery, if you cannot do because of, say, coexisting morbidities or not no fitness for anesthesia, then you can embolize as well. So, surgery remains first choice. If the patient is not fit for surgery, then you go for embolization. So, is this clear regarding the management of patients with epistaxis? So, here they have given you clearly that there is multiple bleeding points. So, when you have multiple bleeding points, will you go for direct therapy first or indirect therapy first? You will go for indirect therapy. If it was single bleeding point, you would have gone for direct therapy. If this would have failed, then you would have gone for surgery. In surgery, I have told you the order. If the patient is not fit for surgery, then you will go for embolization. Okay? All of you are clear? So Swaraj Kieselbach's plexus is a very common question. It's a plexus present in the anteroinferior part of the septum, formed by all the arteries that supply the septum except posterior ethmoidal artery. Okay? Yeah, now let's go to the next question. A 35-year-old patient presents to you with a unilateral nasal mass and nasal obstruction. Okay, there is a grayish white mass observed in the nasal cavity that is extending posteriorly up to the choana. Posterior rhinoscopy reveals a mass in the choana and the nasopharynx. The patient denies history of any sorts of epistaxis, recurrent, provoked, unprovoked. There is no bleeding. Which of the following investigation should be the most appropriate to further evaluate this patient? X-ray of the nasal cavity, non-contrast CT scan of the paranasal sinuses, MRI of the head and neck, endoscopic examination of the nasal cavity. So can you tell me first of all with this clinical question that you know unilateral mass, grayish white mass going to the choana, present in the nasopharynx, no bleeding, what is your diagnosis? See, the diagnosis is going to be AC polyp. Okay. Black Panther, it is not going to be JNA because it's not having bleeding manifestations and it is not presenting to you in juvenile age group. So the answer is going to be an anthracoinal polyp, not ethmoidal polyp, because it's not bilateral. It is not a grayish white, not like a grape, a bunch of grape appearance. They have not given. It's not growing anteriorly. So all the features are suggestive of ethmoidal polyp. If it is bilateral, growing anteriorly, bunch of grape appearance. But this is unilateral, going posteriorly, grayish white, then it is going to be anthracoinal polyp. So now we know that this is an anthracoinal polyp. Now, how do we diagnose an anthracoinal polyp? The investigation of choice will be a non-contrast CT scan of the nose and the paranasal sinuses. Now, if the same question would have been given and asked you what is the treatment of choice, and the options would have been medical management with steroids, number 2 Caldwell operation, number 3 FES, number 4 polypectomy, what would you write the answer? So if the same question was given as the same clinical stem, the investigation is changed to treatment of choice, what will you do? Yes, so the treatment of choice will be FES. Very good. Now, Aftan, why not nasopharyngeal carcinoma? So, first of all, whenever there is a nasopharyngeal carcinoma, it originates from the fossa of Rosenmuller. Here, the mass is observed to coming from the nasal cavity and growing towards the nasopharynx, and they have told you it is a grayish white mass. Now, if it is an NPC, they would have told to you about an ulceroproliferative region present in the fossa of Rosenmuller, extending from nasopharynx anteriorly to nasal cavity. Second thing, they would have typically mentioned to you with lymphadenopathy, because that is the primary hallmark. Even before the primary tumor is visible, there is cervical lymphadenopathy. Third, the age would have been not 35, it would have been 50, 60 above, because the age of NPC is more above 50 to 60 years of age. And in NPC, they will have some amount of blood stain discharge. Here, they have clearly mentioned no bleeding at all. So, with all these features, your NPC is out. Okay. Yes, Abdullah, it comes from the maxillary sinus. From the maxillary sinus enters the nose, and from the nose it goes behind into the nasopharynx. So most of the time when we are seeing, we cannot see its origin from the maxillary sinus. What we can see is a mass in the nose going to the nasopharynx. So observational finding will be this. On CT, you can appreciate that it is coming from the maxillary sinus going into the nasal cavity and from there into the nasopharynx. Yes, Himanshu Sharma, if you've already done my videos, RR videos are very, very comprehensive, very quick. I have covered almost all topics in RR and try to cover almost all images also in RR. So you can definitely go to the examination with rapid revision. I'm confident you will get good marks of ENT with my rapid revision as well. Okay. Okay, so let's go to the next question. A 15-year-old adolescent presents to you with sore throat and fever. On examination, the tonsils are enlarged and red, and there is whitish yellow dot on the surface of the tonsils. So, enlarged red, whitish yellow dots. Which type of tonsillitis is it? Acute superficial, follicular, parenchymal, or membranous? So, Uttam, more or less, my content and my notes is the same. It is going to only have updates of the recent times. Like, for example, I gave you an update of beta trace protein. There is some updates of the embryology. So, updates are there in the recent versions, but of course, the content will be told to you in a little more polished format in the recent recordings that I have given to PrepLadder. Good. So answer is going to be B. So if we see different types of tonsillitis, if we appreciate that the tonsils are just congested, not enlarged, it is going to be superficial. If you see there is follicles, whitish yellow dots on the surface of the tonsil, it is called as follicular. If the tonsil is congested, meaning red and enlarged, then it is going to be parenchymal. So it is red plus enlarged. Then it is going to be parenchymal. And lastly, you have got the fourth one, which you see a membrane limited to the tonsil, which we call it as membranous tonsillitis. So these are the four types of tonsillitis. Okay, let's go to the next question. A 17-year-old male presents with a history of recurrent epistaxis and nasal obstruction on the right side. Now you see the question. Epistaxis and nasal obstruction in a juvenile age. This is enough. You don't need to go any further. You will be able to get your diagnosis. So this first line will tell you my diagnosis is this. All those who think the diagnosis, please answer in the chat box. On examination, there is a globular pink mass in the posterior part of the nasal cavity with septum being pushed on the opposite side. It shows posterior rhinoscopy shows a globular mass with dilated blood vessel. They have told you probe test and digital palpation is contraindicated. Which of the following is most likely diagnosis? Absolutely right. The answer is going to be juvenile nasopharyngeal angiofibroma. Now, if they asked you the same clinical stem and asked you what is the investigation of choice, now what would your answer be? Yes, Shafi, I'm coming there. What is the investigation of choice? I'm waiting for all of your answers. The investigation of choice is going to be a contrast enhanced CT scan. So CT is the investigation of choice. MRI is done only when there is an intracranial extension or cranial nerve palsy or association with major blood vessel like carotid. Then only you're going to do MRI. So to see cranial extension, nerve palsies or blood vessel like carotid involvement, then you will do MRI. Now, can you tell me what is the hormone this tumor is dependent on for its growth? What hormone is this dependent on for its growth? Is it estrogen, progesterone, testosterone? What? The hormone that it is responsible for its growth is? Very good. It is responsible is testosterone. Very good. Then if I ask you the same question, is this a disease of exclusive males or females or can be seen in both? It is exclusive to whom? It is a disease that is exclusively seen in, absolutely right, it is seen in males. It is seen in juvenile age group. Already they have told you probe test and digital palpation is contraindicated. How do you identify the feeding vessel to the tumor? By doing angiography. So on angiography, what is the most common feeding vessel to this tumor? Which artery is the main feeder to this tumor? Yes, absolutely right. It is your internal maxillary artery. And then what is the treatment of choice? The treatment of choice is embolization followed by surgical excision. So you're going to identify the feeding vessel and then you're going to do the surgery. So embolization followed by surgical excision will be the treatment of choice. So the clinical stem, you should know the keywords. Keywords याद है तो diagnosis आराम से आ जाएगा. What you need to know is क्या चेंजेस हो सकता है. डायग्नोसिस पूछ सकते हैं, इन्वेस्टिगेशन पूछ सकते हैं, हार्मोन पूछ सकते हैं, एक्सक्लूसिव पूछ सकते हैं, एंजियोग्राफी पूछ सकते हैं, ट्रीटमेंट पूछ सकते हैं. So only variations you should be able to identify in your head. But clinical long stem question में energy waste मत करो, energy को conserve करो, know the keywords, pick up the keywords, join the dots, get to the answer very quickly in the exam. ठीक है? Fine. Let's go to the next question. A 45-year-old male presents to the ER with severe neck pain, difficulty in swallowing, and rapidly progressive swelling in the submandibular region. On examination, he is febrile and there is bilateral swelling and erythema of the submental area and the submandibular area up to the angle of the mandible. Patient denies any recent dental procedure in the head and neck region. A preliminary diagnosis of Ludwig's angina is suspected. Which of the following criteria is not consistent with the diagnosis of Ludwig's angina? So, इसमें से कौन सा point is not telling you of Ludwig? Now, there is a criteria called as Goldring's criteria for Ludwig's angina. According to that criteria, one of these options does not fulfill the criteria. Which is that particular line? It's cellulitis and not an abscess. The spread of infection is via connective tissue spaces and not through lymphatics. It is always unilateral. There is presence of serosanguinous fluid in the serosanguinous discharge and not pus. Good. Many of you have answered this absolutely right. So, as per the definition, the Ludwig's angina is always a bilateral condition. It is not unilateral, always bilateral. It is the cellulitis of the submental and the submandibular space. It is not an abscess. So this is a correct statement. The spread occurs through connective tissue, not connected. It is through connective tissue spaces and not through lymphatics. Normally, the infection spread occurs through lymphatics. Here, it is not through lymphatics. It is via connective tissue spaces. So this is also correct. There is serosanguinous fluid because it's a cellulitis. There is serosanguinous fluid and no pus. This is also correct. So the false statement is it is not unilateral. It is bilateral. And one more statement is there to this criteria. There is sparing of submandibular and sublingual salivary gland. So although it is involving the submandibular space and the sublingual space, the glands are spared. So the submandibular and the sublingual glands are spared. So I hope everybody understood this criteria. Okay, let's move on to the next question. A 2-month-old infant presents with high-pitched inspiratory stridor that worsens during crying. The stridor is absent when the infant is placed in prone position. On examination, omega shaped epiglottis. अभी omega shape देखते ही एक आंसर आ जाता है दिमाग में, so you know what is the answer. So which of the following is most likely diagnosis? Tracheomalacia, laryngomalacia, epiglottitis, vocal cord palsy. Now इतना simple question है कि कोई भी answer करेगा. 2-month-old child, inspiratory stridor, more in supine position, relief in prone position, and the stridor increases on crying. Omega shaped epiglottis is all very classical of laryngomalacia, which is the most common congenital anomaly of the larynx. So amongst all the congenital anomalies, the most common congenital anomaly is laryngomalacia. So you will see that there is prolapse of the airy epiglottic fold, and as a result they have a epiglottis which is called as omega shaped epiglottis. Okay, yes. A 55-year-old patient presents with carcinoma involving the middle third of the vocal cord. What is the treatment option that is most appropriate for this patient? Radiotherapy, microlaryngeal surgery, vertical hemilaryngectomy, subglottic laryngectomy. So answer in the chat box. So Avtan, I think if you want to revise it quickly, I think you can go for rapid revision. Keep revising the rapid revision because they're very concise. I think it is 14-15 hours. So you can do it once in a month also, 15 hours. Like one day you sit, you'll be able to revise. Put it on a 1.5x speed. You will be able to do it in 8-9 hours itself. So that will give you sort of all the important information that you have to recall. Do it once in 2 months or once in 3 months so that you'll have a quick memory of whatever you've forgotten. Okay. Yes, so if we are talking about a patient who's having carcinoma of the middle third of the vocal cord, what is the treatment of choice? The most appropriate treatment of choice is going to be microlaryngeal surgery. So if I have to summarize the treatment of a patient of CA larynx, so whenever we are talking about CA larynx, see again, this is a shortcut for your examination, nothing that you have to apply directly on each and every patient. Tumor board will determine based upon the age, comorbidities, prior surgeries, prior history of radiation, all that will determine the treatment. But MCQ के लिए अगर solve करना है तो this is your shortcut. तो carcinoma of the larynx अगर वो stage 1 या stage 2 में है, so if there is a patient who is having a stage 1 or a stage 2 malignancy, then what will you do? The treatment of choice will be RT. Okay, radiotherapy will be the treatment of choice. इसमें सिर्फ एक ही exception है. What is the exception? If there is a carcinoma of the middle third of the vocal cord. So if you have a carcinoma of the middle third of the vocal cord, then you are going to go for microlaryngeal surgery. ठीक है. So for all stage 1 and stage 2 patients को क्या आंसर लिखोगे? RT. Exception क्या है? Carcinoma of the middle third of the vocal cord, where you'll do MLS. Okay. Then you have got stage 3 and stage 4. So if you have got early stage 3, then you're going to go for chemo RT. The treatment of choice will be chemo RT. Now there is again one exception here. The exception here is if there is a carcinoma of the epiglottis. So if there is a patient who has got carcinoma of the epiglottis which has spread to the pre-epiglottic space. So there is a carcinoma of the epiglottis which has spread to the pre-epiglottic space. In this patient, we have labeled it as stage 3 because of involvement of the pre-epiglottic space. So here we can do a hemilaryngectomy, a partial laryngectomy, and not a chemo RT. So here we are going to do a partial laryngectomy. Now, if you have a patient who's having advanced stage 3 or stage 4, then you're going to go for total laryngectomy. So this is going to be a shortcut for your exam to be able to answer very quickly. तो हर कोई जो stage 1 stage 2 में है RT, उसका exception है carcinoma of the middle third, जहाँ पे MLS microlaryngeal surgery. If there is a patient having stage 3 malignancy, chemo RT will be the treatment of choice. Exception is carcinoma of epiglottis which spread to pre-epiglottic space. Vocal cords are normal, vocal cords are mobile. सिर्फ pre-epiglottic space involvement is making it stage 3. So here you'll go for partial laryngectomy. But if there is an advanced stage 3, stage 4 disease, then you'll go for total laryngectomy. So I hope this is clear with everyone. Stages I will explain to you in the last shuffle. We have 2 more questions to go. So let's do that quickly and then we can go how to stage the tumor because it's going to take a little 5 to 6 minutes time. Fine? Okay. A 2-year-old child presents to you with a biphasic stridor, a change in voice, and a barking seal-like cough. Anteroposterior view of the neck shows a steeple sign. What is the most likely diagnosis? अभी ये तो हर किसी को पता है, steeple sign, thumb sign, biphasic stridor, change in the voice, barking seal-like cough. अभी इससे ज़्यादा तो कोई hint दे ही नहीं सकता examiner आपको exam में. Yes, answer is very simple. The answer is croup. Croup is nothing but laryngotracheobronchitis. Now, if the same clinical scenario is given and if they ask you what is the cause, what will your answer be? Same clinical scenario, 2-year child, biphasic stridor, change in voice, barking seal-like cough, steeple sign. What will your answer be regarding the cause? Yes, it is parainfluenza virus type 1 or type 2. Rhinovirus, respiratory syncytial virus can cause also, but most commonly it is parainfluenza. So you should remember mainly it is viral etiology. So you can see this sign here where there is narrowing of the subglottis resembling the steeple of the church. So this sign is called as steeple sign. Okay, so a 45-year-old patient presents with hoarseness of voice. On examination, you see that there is paralyzed vocal cord is in which position? Midline position. While the normal vocal cord lies in the intermediate position. So paralyzed cord is in which position? Midline. Normal cord is in which position? As it is intermediate position. There is sensory loss noted below the level of vocal cord on the same side. What is the most likely diagnosis? Is this unilateral RLN palsy, bilateral RLN palsy, unilateral SLN palsy or bilateral SLN palsy? See, normal cord तो intermediate में है. What is the normal position of the vocal cord? It is in the intermediate position. So if the vocal cord is coming to midline position, so if the paralysis is causing the vocal cord to come in midline position, what is paralyzed? Is the abductor paralyzed or the adductor paralyzed? When will the vocal cord to come to midline position? So if the abductor is paralyzed, what will happen? Automatically the vocal cord will come to midline position. So which is the only abductor of the vocal cord? It is your posterior cricoarytenoid. This posterior cricoarytenoid is supplied by which nerve? Recurrent laryngeal nerve. So if there is a recurrent laryngeal nerve palsy, where will the paralyzed cord be? Midline position. Now they are saying one cord is in the midline, other cord is in normal or intermediate position. So can I say it is a unilateral RLN palsy? Yes. Now they're telling sensory loss below the vocal cord on the same side. RLN supplies below the vocal cord, SLN supplies above the vocal cord. So again, will this fit to my diagnosis if there is a sensory loss below the level of the vocal cord on the same side? Yes. So whenever you have a midline position, it is abductor palsy. Abductor palsy means posterior cricoarytenoid palsy. Posterior cricoarytenoid means RLN palsy. And sensory loss below the level of vocal cord reconfirms the same. So the answer is going to be unilateral RLN palsy. So now since we had some question regarding the staging, so one very easy way to stage laryngeal cancer, all of you can start writing this while we do this. All of you can keep writing in your books as well. This is a shortcut again. So stage 1. Just go on writing T and M, all of you, to across all the stages. Yes. So if I say stage 1, put the number 1 across the T. Say stage 1, write T1. Stage 2, T2. Stage 3, T3. Stage 4A, T4A. Stage 4B, T4B. 4C, T4C. And regarding rest of them, N0, M0, N0, M0, N0, M0, N0, M0, N0, M0. This is easy for everyone? I'm sure yes. But can it be so simple? No, can't be, right? Unfortunately. So I'll still make it easier for all of you. Now leave stage 1 and stage 2 because this is as it is. Stage 1 is T1 N0 M0. Stage 2 is T2 N0 M0. This is as it is. Now stage 3, how can we write? Stage 3 is T3 N0 M0, or it can be anything. It can be T1, T2, but max it can go to 3. It cannot go beyond 3. But what is happening to N stage? N0 is becoming N1 M0. So if it is T1 N1 M0, it is stage 3. But if it is T1 N0 M0, stage 1. So now you understand the difference. So if somebody asks you what is T1 N0 M0, stage 1. But if they ask you T1 N1 M0, then the stage shifts to stage 3. So this is clear. Now let's do for T4A. T1 or T2 or T3, max it can go to T4A. What will happen to N1? N1 becomes N2 and then it is N0. Simple, right? Now let's do 4B. It can be anything, T1, T2, T3, 4A, 4B. But what is happening to N2? N2 is becoming N3, M0. Now what is 4C? It can be any T, any N, M1. So if it is M1, then it is 4C. If it is N1, it is stage 3, N2, stage 4A, N3, stage 4B, and M1 is 4C. So I hope everyone understood how to stage. Mohammad, I hope your answer is clear. Any other questions from your end if you'd like me to answer and simplify? And Jay Malia, you can get, I mean, unfortunately, we have stopped sharing the PDF. So you can come back to this session and you can get a understanding, or you can review back whenever you would want to from the same YouTube link that is present on the session. Okay. My RR notes and RR videos are already updated on the site. So all those who are interested in going through the RR, all these short tricks and tips and multiple important points have been told in a very simplified format. So all those who are interested can look into the RR videos, or would want to go into detailed explanation can go into detailed videos. The detailed videos are for about 35-36 hours and the RR videos are for 15-16 hours. So somewhere you will find that ENT is going to be a quick cakewalk for all of you, and I have tried my best to simplify the subject to as much as possible. Okay. So Naresh, noise-induced tinnitus is something that is very difficult to treat. Again, intratympanic steroids to certain extent, systemic steroids to certain extent, and also intratympanic platelet-rich plasma (PRP) injections have shown in the trials. So that's the only treatment that we have available for noise-induced tinnitus. Okay. Okay, so with this, I hope you understood the different clinical questions with me through our Pro QBank. We have a QBank that is the India's only clinical QBank that we can proudly tell, and this has been monitored and checked through various levels, and we have at most tried our best to keep it error-free. So all those who want to take only the Pro plan, which has only the QBank, it has got the test series, it has got the treasures and PYQ. So this is not having video lectures, this is not having RR videos. Only thing that you need to practice, just practice. You have done your things from somewhere or from yourself or whatever, you just want a practice of question. I think this is something for some, or those people who are appearing for the exam and want to get a quick practice of only the MCQs. So this plan is exclusively for them. So it's a must have for your next preparation, because it's the India's only next QBank that is clinically oriented. It will tell you all the right answers, it will tell you the wrong answers, it will give you clinical based scenarios. You can flip between clinical based scenarios and one liner. So the same explanation, they'll give you clinical question, and if you flip You can choose a one-liner of the same content. You can have a comprehensive explanation of all right and wrong answers. You have integration of pre and paraclinical subjects as well. It will give you learning objective and treasures, which is a good last minute revision for all of you to study the important points or details of that particular topic. Okay. After no, unfortunately, we have not done a Hindi video because we believe that upcoming examination, the next examination is going to test your comprehension and knowledge with English, and we want you to do it with English itself. So when the practice is in English in your exam, mental fatigue nahi hoga because you're going to do the practice also there, and the exam is also going to be in English. So we have not done English videos at all from PrepLadder. So, with this, I'll take your leave and I hope you guys enjoyed my session. Thank you for staying tuned and listening to me. I'll come up with more interesting sessions. If you have any doubts or if you want any topics to be discussed in particular, if you have any difficulty in ENT, do let me know in the chat box. I will be more than happy to come up with those sessions for all of you on YouTube. I'll take a leave and I'll see you all again in my next session. Until then, take care and bye bye.